On behalf of the India Oxford Initiative at the University of Oxford, I'd like to give you a really warm welcome to this virtual event. We are delighted to have with us two distinguished guests, the Honorable Minister in the Government of Kerala, Srimati K Shailaja, who is recognized globally for her leadership in health crisis and the empowerment of women, and Sir Richard Peto, who is Emeritus Professor of Medical Statistics and Epidemiology with very many accomplishments to his credit. It is a privilege to be opening in such excellent company and an honor to mark the beginning of our program this academic year with this inaugural webinar and handing over to Richard to chair for subsequent discussion. My name is Mallica Kumbera Landrus, and I am the chair of the India Oxford Initiative and the keeper of the Eastern Art Department at the Ashmolean Museum. Although we're not able to meet in an Oxford lecture theatre as we initially planned, this virtual event has given us the opportunity to welcome many more of you than we could have possibly fit into a single space. Oxford has long connections with India, the earliest recorded to 1579. The first Indian students arrived in Oxford in 1871. Today, India is our sixth largest source of international students and fifth largest source of academic staff. In response to demand for greater collaboration across the university on India, the India Oxford Initiative was created in 2018 as a mechanism to build and sustain partnerships between individuals and institutions in India and academics and researchers at the University of Oxford. It acts as a hub to coordinate India-related activities across the university and as a contact point for potential external partners. The initiative seeks to develop equitable partnerships with Indian organizations and institutions, leading to collaborative academic research of mutual benefit. We particularly look to support students and early career researchers develop successful collaborations across all academic disciplines. Within Oxford, the initiative aims to attract participants from around the university and includes representatives from all 5 divisions at Oxford. Indeed, the initiative is an excellent example of how colleagues from across the university have come together with the aim of achieving an impact greater than the sum of our parts. As a reminder, we are live streaming and the video will subsequently be available on our website. Welcome again to our audiences, both nationally and internationally. And so I now have the great pleasure of handing over to Richard.
Okay, thank you very much indeed. Thank you. Well, you study Eastern art, which is how to enjoy life. I study epidemiology, which is how to stay alive. And I think that Health Minister Shailaja Teacher is definitely an exponent of epidemiology to help people stay alive, and probably of Eastern art as well. Anyway, that's enough of that. I've had great pleasure collaborating with various Indian colleagues over the decades, and I look forward very much to hearing what is going to be said from Kerala. I was pleased to get the invitation to share this because I had read about Shailaja Teacher's work on Nipah virus and also the early work on COVID. And this was written about in the English newspapers. And then I was surprised to find that when the Prospect magazine ran last month a competition of all possible fields of human thought, male, female, any country, science, art, to determine who was the greatest thinker in the world, Shailaja Teacher finished up being top of the poll, beating the Prime Minister of New Zealand and beating various philosophers and so on. So we very much look forward to what you say. And it's very nice to be hearing from somewhere where people have actually tried to be really seriously rational in response to epidemics, this epidemic and previous epidemics, and to be hearing from somebody who's helped them to do so. So, Shailaja Teacher, we look forward to hearing from you. There will be questions and answers after this, but I want mainly to let people listen to what you want to say. So the questions will be coming in through the chat function, and they must be brief, no speeches. We want questions to you, which get responses from you. We want to hear from you, and I look forward to doing so now. So Shailaja Teacher, over to you.
Thank you, sir. First of all, I want to express my thanks and gratitude to India Oxford Initiative for inviting me for this August gathering, this webinar. And I want to express our experiences on this COVID-19 epidemic and this pandemic. I want to show the some of the key points through my slides. And the first of all, I wanted to say that let us be realistic, that the pandemic is far from over. We were just in the middle, we can say so. The pandemics will come and go. But once the pandemic ends, the only relevant question would be how many deaths we averted and at what cost. For example, we all know about the Spanish flu of 1918, 1920, caused approximately 50 million deaths. And considering the world population of that time, it's really high number. And we know the Spanish flu they predicted 3 waves, maybe 4 waves. And if we take the example of this Spanish flu in 1918, the most devastating wave was the second wave that occurred in the winter of 1918. And there is almost a similar picture for COVID-19 also. It is predicted that more people in European Union will be infected in the second wave. The graph shows that thing. And however, the deaths would be significantly less than the first wave, because this time the countries in Europe is better prepared, while an early peak in the first wave proved disastrous. That's exactly why we need to delay the peak. The most important thing about this pandemic is to delaying the peak. Kerala is doing that thing. Delaying the peak is the most important thing, and that was one of our primary objective in Kerala. Because considering the demographic and epidemiological vulnerabilities of the state, and an early peaking would have been much more disastrous. Kerala have the demographic and epidemiological vulnerabilities which is not favorable for this COVID-19 pandemic. As shown in the chart, we can compare these things to UK also. Our population density is 859 in square kilometer. I think UK it is 275 in square kilometer. And also the prevalence of diabetes in adults, that is 19.4% in Kerala. I think that is 6.2% in UK. But the elderly population, that is 18%. Out of the total population, 18% is the elderly population in UK. That is 14%, not much below. It is 14% in Kerala. And also the prevalence of coronary heart disease, it is 3% in England and 4% in Scotland, we think so. But it is 7.4% in rural area of Kerala, and also 11% for urban Kerala. This is the vulnerabilities we are facing in front of this COVID-19 epidemic. And we want to delay the peak. If it goes up above the health system resilience, threshold, it will be much more dangerous to us. So the delaying the peak have three advantages. We can see so. First, we got some breathing space or some time for preparing our health system before we reaching the peak. Second advantage of delaying the peak is we were able to control the pace of the epidemic so that it remains below our health system capacity threshold. And we were able to know more about the disease. This is a new virus and a novel virus, and we were able to know more about this disease and its management during this time. So we want to delay the peak of the epidemic during this season, pandemic during this season. And we can now examine where do we stand. For understanding the advantage of this, we can compare it with the situation over there in UK. We can examine this chart for that. And the first case reported in Kerala, that was in 30th January. And in UK, I think that was in 31st January. And the total cases, there is nothing in the total cases, but we can examine that also. That is like this. And case per million, 13,157 in UK and 11,891 in Kerala. But we should have to examine the deaths. Then we can understand the actual thing about the delaying of peak, what we achieved from the delaying of peak. Total death in UK is 44,998, and now this today that in Kerala is 1,352. And death per million, that is 40 in Kerala, 662 in UK. And case fatality rate, that is 5.02. I think I may be correct. And 0.34 in Kerala. That the delaying of peak have some achievements. This chart shows that. And that was our intention. Most important aim is to delay the peak and to reduce the mortality rate as far as we can. And for this, we have some strategies of our own. We have a four-pronged approach here. First is with regard to potential source of infection, including the imported cases from abroad and their contacts. We had very good and now also having a very aggressive tracing and also strict and decentralized quarantining, focused and strategic testing and diagnosis to declare our priority of testing and diagnosis. We have very good protocol and guidelines. We prepared that. And the fourth one, that is early and foolproof isolation of diagnosed cases and best possible treatment for the cases. In this part, we improved our health system capacity more than anything. And the second strategy is to minimize the virus circulation in the society. And we declared a huge campaign called Break the Chain, wearing mask, washing hands with soap, and also using sanitizer, and to prevent the gathering of the people, etc. The human beings are mobile and we cannot prevent their mobility completely. But we had a very good campaign and some good result out of that, out of this Break the Chain campaign. And also the third one is to shield the vulnerable population against the virus, as we are more vulnerable about this old age population, and also the non-communicable diseases, lifestyle diseases are rampant in Kerala because of the lifestyle. And we have to shield that old age and also the comorbid people from the direct transmission of the virus. And we applied this reverse quarantine of elderly persons with high risk comorbidities, pregnant women, and also children. And also home-based care, that is the most important thing. And we have so many volunteer groups and also so many field workers who directly go to the doorstep of each and every houses and supply the medicine for NCDs to the doorsteps, and eatables and other essential goods to the doorstep. The volunteers and also the health field workers were working throughout these 9 months to achieve this result. And that home-based care and palliative care, etc. And we introduced a very good program called Grand Care Program for elderly especially. And the last one is to ensure the social safety net, that community kitchens, etc. Our Honorable Chief Minister declared 20,000 crores package at that time to supply them the essential eatables and other things, essential goods as a kit to each and every home to ensure no one is starved. And also special migrant camps also. We have so many migrant workers here, thousands of migrant workers here. And we arranged very good camps for the migrant workers and provided them foods and medicine in free of cost. And that is our the fourth strategy. And what is the effect? The declining CFR while cases are peaking, that was the good result. And there are so many activities I'm not explaining. And out of this hard work, we were able to decrease the case fatality rate, even though the number of cases are increasing after the lifting of the lockdown. The lockdown was lifted here. Lockdown was declared here on March 24th, and lockdown was lifted on May 3rd. And all the people, all the expatriates started to coming back to Kerala by air, by water, and by road and rail. From every part they were coming. More than 10 lakhs of expatriates reached Kerala during this time, and the cases began high, and the transmission occurred at that time during these months, May, June, July, August, September, October, etc. But even though the number of the cases increased, but the mortality rate then it decreased. It is because of our preparedness and the health system capacity. We have very good advance in that. We provide more ICUs, ventilators, more beds, and oxygen cylinders or low flow oxygen. Everything we arranged during this season. And that is why on May, the case fatality rate is 0.77, and up to September it become diminished to 0.38, and now it is 0.30. And that is the effect. And also the death per million, if we calculate the death per million and we can compare to other states of India, Kerala's death per million is 40. But the neighbor state, Karnataka, it is 179. Tamil Nadu, it is 151. Maharashtra, it is too high. And in India, average, it is 87. And but the pandemic is still on. And we will have to continue this delicate and dynamic titration of lives, livelihoods, and the health system capacity. We have to work continuously on that. Until we have an effective vaccine, we are all working. The whole human race is waiting, eagerly waiting for a vaccine. Then only we can stop it fully. Otherwise, the pandemic will be here. It is here. We should have to live with the pandemic, live among the pandemic. And we are eagerly waiting for a vaccine. And for that, Oxford University is one of the greatest hope with your vaccine. I think your vaccine already in its third phase of clinical trial, and we are eagerly waiting for that vaccine. I want to conclude my presentation. We as humanity would definitely win over this pandemic. Definitely we will win. It's just a matter of time and our collective synergy. Until then, let us break the chain. And once of all, I want to express my thanks to all. Thank you.
Thank you very much indeed, Mr. Shailaja Teacher. I can see why they call you Shailaja Teacher now. Very good. I suppose from my point of view as an epidemiologist, one of the most surprising findings is the low case fatality rate. And I wonder what the main reasons for that are, whether it's that you're getting more cases detected, whether you're getting better treatment, or whether it's very strongly related to age distribution. When if you have managed to protect the elderly, then this would have an enormous effect on the case fatality rate. I mean, you put up the official government figure for British deaths, which is about 45,000. Well, the British government has two figures. One is about 45,000. The other is about 55,000. My estimate, working together with Professor Valerie Burrell, is that the real number of deaths here has been more like 75,000, not 45, not 55, but 75,000. But that many of those deaths have been of people who were actually on the point of dying anyway. There were people who were in care with maybe totally disabled with stroke, maybe seriously disabled with dementia. They were so near to the point of death that it was quite plausible to ascribe the death to something else, such as stroke, end-stage Parkinsonism, dementia particularly, back in March and April. And that if you include those deaths, then actually the real number of deaths here has been 75,000, where COVID was a cause of the death. But many of those were deaths where really the patient was losing nothing very substantial in the way of quality of life. And of those 75,000 deaths, something like 50,000 were above age 80, and another 16,000 were age 70 to 79, leaving about 9,000 under age 70. And so if we'd taken out the old age, then we would have had very low numbers of deaths. And I wonder whether you've managed to protect your elderly better than we did. We had them in care homes. The care homes then got infected, and many people died. Is it mainly a question of age distribution, the low death rate, or do you think there are other things that explain it? And I was also interested in you emphasizing treatment at home as well. I wondered if you could comment on that. I'm sorry, I'm asking my own questions rather than those that are coming up on the chat, but I will get to other people's questions in a minute. So age as an explanation, and tell us more about why you're emphasizing home care.
I think you are asking me about the number of tests. Is it that?
The number of deaths has been, sorry.
Yes.
Okay. I'm seeing, okay. In the UK, the number of deaths that have been officially ascribed to COVID is actually even worse than the number you put up. You put up the number 45,000 for the UK. And in fact, I think the real number has been about 75,000. And the reason for this difference is that particularly in March and April, when people were in the process, when very old people were in the process of dying from something else, where the death would have been certified as dementia, stroke, maybe somebody who's been long-term paralyzed by a stroke and is in care, or things like Parkinson's disease, late-stage Parkinson's disease, when they're in the process of dying anyway, then some of those deaths, they got COVID. Tests were not available for COVID at that time in March and April, and they could plausibly be put down as dying of what they really were dying from anyway. So it was like the last moment in a death that was actually taking place for something else. So the real number of deaths has been bigger than the government figures, but many of those were deaths where there was little, if any, loss of quality life. But these big numbers of deaths, whether it's 45,000 or 75,000, it's been predominantly deaths in old age. The number of deaths before age 70 has been only about 9,000 in this country, whether it's 9,000 out of 45,000 or 9,000 out of 75,000. It's only about 9,000 before age 70. And I wondered whether your low numbers were because you had managed to protect you to avoid an epidemic of infection in the elderly, which is what happened in Britain.
Yeah, we are applying a scientific approach for testing. Here, we first thing was to test each and every symptomatic cases. We are giving priority to the symptomatic cases. If any symptoms occur, we will test them properly. And second thing, we are testing the direct contact, the high risk people, and also the most vulnerable people. We completed the testing in each and every government homes for the poor and also the old age people. And that way we are testing the properly, not increasing for the sake of increasing. We are testing them properly, and now we are testing an average of 50,000 or up to 70,000. That is the number of tests here. But the question is that where you are testing and whom you are testing. That is the most important thing. We are testing the symptomatic cases because we are not avoiding any influenza like illness or any severe acute respiratory infection, etc. If we show that symptoms, we are testing each and everybody. That is a scientific approach.
Now, other people's questions. What are the communication strategies that you mainly used? In what ways do you, as Health Minister, mainly communicate with the population? That's one question. And the second question is, what are the lessons for the UK from the low death rates in Kerala? Are there lessons about utilising community health workers, police, local, self-government? So do you feel that there are any lessons to the UK? You don't have to comment on that if you don't feel able to. But the first question, what were the communication strategies you chiefly used to communicate with your population?
Yes, the communication is the most important thing. And each and every day, our Chief Minister is briefing each and everything to the population, the whole population through our TV channels and other medias. And we have very good evaluation meetings and so many meetings of that kind. And after that, the Chief Minister is describing all these things to the media and to the population. And also me as a health minister, I am also describing the technical points, the health department implementing. And my secretary also is conducting some technical sessions on this COVID-19, the knowledge we are getting from other places of the world, other countries, and we are explaining all these things to the people. And also we are carrying on the campaigns also, that break the chain campaigns, etc., through local self-governments. We are explaining everything to the local self-bodies, and the local self-governments are campaigning all these things to the grassroots level, and the communication is going on that way. And the number of the tests, again, I am saying that we should have to examine the everything, not only COVID, but other pandemic, other epidemics, other infectious disease, etc. during the season. We are each and every day we are examining the other the excess death analysis we are doing. The fortunate thing in Kerala is that when comparing to 2019, the total death decreased in Kerala. It is not increased. That is a very good achievement, we can say so. That is why I'm saying that increasing the test for the sake of increasing, it will give no results. We should have to test in a scientific way, and there should be a strategy. We are doing it strategically, and through our primary health center, we are examining the chronic obstructive pulmonary disease. We have some mechanism in our grassroots level to observe the chronic obstructive pulmonary disease and ILI case, RE cases, etc. That is why I am saying that our strategy for testing is very good, and we have a good result out of that.
Another pair of questions, sorry.
Sir, your mic is mute.
Which aspects of the Kerala pandemic response are you most proud of, and which aspects of the Kerala pandemic response do you wish you had done differently? And a related question is, how do you manage to limit the spread of fake news relating to the virus? So it was 3 questions. Which aspects of your response, the response in Kerala, do you feel the government should be most proud of? Which aspects of the response do you think you wish you had done differently if you look back on it? And how have you managed to contain the spread of fake news? 3 questions.
Yes, sir. We all know that after 30% of the people become infected, then only this pandemic will recede. The scientists are saying so. The most important thing is to delay the peak of the infection. Otherwise, if it go out of the health system capacity threshold, we should have to face more deaths, especially among the old age people and vulnerable people. But we are trying to diminishing the peak or the delaying the peak and to save more lives. And we have a very good system. We made our system capacity threshold to make this pandemic below that, and we supplied more ICU ventilator, etc., more human resource we pulled there, and we are giving good trainings for ICU care and other thing. Each and every day we are monitoring what is the ICU care we are having, and giving new knowledge we are getting from other parts of the world. And every time we are refreshing our human resource, especially the health community, to face the problem. And that way, I think we are able to decrease the death rate and to save the lives of the people.
Yes, can I come back to the second question? Are there any aspects of the way things were managed in Kerala that when you look back, you wish you had done things differently? That's the second question. Are there things that you feel you wish you had done differently now you look at it? Are there any matters of regret in the way the response went? Overall, the response has been good from the government and successful, but are there any aspects of it that you would do differently given what you know now?
Pardon, sir, I can't understand.
Oh, sorry. Do you feel that there are any, when you look back on the past 9 months,
Okay.
do you feel that there are things that you wish you had done differently? Are there things you wish the government had done differently?
Yes, sir. I think this is a litmus test to the system of governance throughout the world, and how to tackle the problem of this kind of pandemic. It will come one after other. Nipah came here, and after that, this corona virus came, and other infectious diseases are also here. And the question is that how we can tackle this problem, and that is a system of governance. I think decentralized planning should be there. I think more money should be put for the health sector, and we should have very good primary health sector and public health system. Without the proper public health system and without addressing the needs of the poor people from the grassroots level, we cannot we cannot tackle this kind of difficulties. And all of a sudden, no one can tackle this problem, but we should have to build up a system of decentralized planning and public health system. In Kerala, 1957 onwards, we are trying to increase the access for the poor people, for the very poor people. They are accessible in the public health system, and we are giving quality treatment and affordable treatment in free of cost for the poor people. And this time also, the COVID pandemic treatment, it is totally free to everyone, not only for the poor people, but also we are treating the people in government sector free of cost. And that is the thing. And we should have what is the money we have remitted for this health sector. That is the most important thing. In rich countries, they are putting more the GDP 18% or 20% they are giving for the health sector. I don't know, but here in our country it is the 1% of the GDP. It is only for health. Only 1% is for health sector. That is not sufficient. But in Kerala, through the decentralized planning, we are overcoming this our difficulties of low income or economic difficulties. We are overcoming that thing through the people-centered planning and collective activities, and this people-centered decentralized planning. We are doing that. So through these 4 years, throughout these 4 years, we improved the public health system much more, and we converted our primary health center to family health center, and up to evening there are outpatient system there, and so many clinics we decentralized to the grassroots level. That COPD clinic called the Shwas clinic, and depression, for examining the depression of the people, we have Ashwas clinics, etc. So many things. And we decentralized the 3 super specialty to district level. From medical college level, we put it to the district level, that neurology, nephrology, and cardiology. We are taking this to the people for making it accessible to the poor people. And the whole world is discussing about the governance system. That is the only method to tackle the problems.
Yes, Kerala has famously low death rates in childhood and early adult life, but then in middle age, the death rates are not very satisfactory. I mean, you have a lot of obesity and smoking and high blood pressure, and you have the main problems of middle age. It's really in childhood where Kerala was absolutely ahead of almost anywhere else in the world, when in the early reduction in child mortality. And you say it started about the year you were born. Now, one question, as people asked, to what extent are school children still going to school? To what extent are students still going to university? Are students continuing to attend school and college, or is this being disrupted? So are they continuing? And if they are not continuing, is this going to damage literacy and education?
Sure. I think Kerala is facing so many vulnerabilities, even though we are in the first place for some indices in the health sector, that lower mortality rate for maternal mortality rate, infant mortality rate, that is very low in Kerala. I think infant mortality rate is 7 out of 1,000 live birth, and maternal mortality rate is 30 out of 1 lakh. But we have some other first place also that is not very good. That is, as you said, the obesity, this hypertension, and also this diabetic. Kerala is known as the diabetic capital of India because of the lifestyle. When the socio-economic standard become better in Kerala, among that, these vulnerabilities are also increased. The lifestyle disease, because of the lack of exercises, physical exercises, and the change in the eating habit, etc. The Kerala people are becoming more vulnerable due to this non-communicable disease. Cancer is also rampant here. That kinds of. Now we are trying to address that problem, and we started a mission called Ardram Mission. Through that, our slogan is to make our government hospitals, public health system, people's friendly and also high-tech. And we are now focusing on prevention and to early detection also, to find out the cases earlier, the hypertension and diabetes. We are now testing all the people, all the population above 18 years for hypertension and diabetes. And that is almost over. And we are addressing this earlier, and we are giving remedial measures for that. I think within 4 or 5 years, we can achieve very good result out of this. And without the kidney failure is rampant here, and the liver transplant, some people have to do that. That is all because of the hypertension and diabetes, etc. And we are addressing that problem earlier, and that way only we can tackle these things. We are focusing on prevention and early detection and giving affordable treatment for the poor people. Your mic is mute, sir.
Just to try. So the overall need is of primary prevention so that to avoid the development of the diabetes and the hypertension in the first place. Now, the question here from somebody is, what happens to overall mortality in Kerala? And you're claiming low mortality from COVID, but you said that the overall mortality has also decreased during this period. So I think this is an answer to the question. People were saying, what happens to overall mortality? Can we trust the statistics? Are the statistics true? So do you think that the statistics for overall mortality in Kerala are true? So it is the reliability that is being asked about of the overall mortality statistics.
Yes, sir, I explained that it is a good result. The overall mortality is reduced in Kerala during this season. I think there are so many reasons for that because of our propaganda and our campaign about the break the chain, etc., and wearing mask and using the sanitizers, etc. It affected not only for COVID-19 but also for H1N1 and dengue fever, etc. That become lower in this year comparing to previous year, and that mortality rate reduced here. And also we had a very good campaign to reduce TB, to eliminate TB, to eliminate leprosy, etc. According to the Sustainable Development Goals declared by UN, we also declared 13 aims in Kerala. That is, one is to reduce mortality, the infant mortality rate, and other is for maternal mortality rate, and one is to eliminate TB, etc. And we are working for that throughout these 4 years, and that also affected. And also the field level work to tackle this pandemic, that also helped us very much. And during the lockdown period, I think the accident deaths, etc., also reduced. And not only because of that, but because we have a very good trauma care project here. We introduced a very good trauma care project, and we have 315 trauma ambulance and on road, and that we launched very good the basic life support with the basic life support ambulance 315. Every 30 kilometers we introduced a new ambulance in Kerala, and in that way also we can save so many lives from accident, etc. And with all these activities, we can reduce the overall mortality in Kerala. That is an achievement, and we have to continue that. When we stop this kind of work for a moment, again it will rise, and it should be a continuous process. And we are doing, amongst the COVID period, we are not forgetting the other thing. That is why I am saying that we are giving equal importance to non-communicable diseases and the nursing for the palliative, who want palliative care, etc. And we are addressing every problem. We are giving equal importance to non-COVID patients also. One part we are giving importance to COVID patients in COVID special hospitals, and the other part we are examining each and every day what happens in the non-COVID sector, whether the operations or surgeries are postponed or not, whether they are conducting in proper time. We are giving instructions to carry on that thing also. And there is a scarcity of human resource. When we supply these human reports to two parts, it become a very great problem. But we are recruiting the temporary staffs to hospitals, temporary doctors and staff nurses we are recruiting, and we are managing the human resource problem also. That way we are balancing these two things. And that is why I think the overall mortality is reduced here.
Well, you have just answered the next question, because the next question was going to be, how has the healthcare system coped with delivering non-COVID related care? I think you have just answered that question, so thank you. You are answering the questions before I'm asking them. And the other question that I think you did not answer is, how have you managed the problem of fake news, the problem of rumors that are not true? we have this problem in the United Kingdom. It is even worse in the United States. Is this a big problem in Kerala? And can you do anything about it? What do you do to try to control untrue news?
Yes, that is a great problem in Kerala also. Even though we are a literate state, but this kind of propaganda is going on. And every day we are watching. Media monitoring is the most important thing. The new media, the Facebook, Twitter, and other social medias, and also the television channels and radio, etc. Everything. Some of our doctors and some of our volunteers are eagerly watching this, and whenever we find a false propaganda, at once we are giving the correct statement, and that is not an easy thing, because the some peoples are using the medias intentionally for false propaganda against government. There are
Yeah.
opposition here also. In each and every part in a democracy, there is a very good opposition, but it is not democratic way. The opposition always they are doing not in a democratic way, but they are attacking, severe attack, and the poor people are uniting for to fight against the against this threat. But the opposition as a political thing, they are opposing us with false propaganda and some false beliefs. Some superstitions are also. Kerala is literate state, and we can easily to find that kind of thing, and we can give the opposite propaganda for that. But
Yeah.
some people are saying like that. At first, they said that nothing to fear, that this is only a simple flu-like thing, and nothing to fear. The ministry is exaggerating this thing and overacting, etc. That was the first part. Their propaganda is like that. And I said we should have to overact, because this is a new virus, and we didn't understand what is the behavior of this virus. The whole world is studying about that. At that time, we have to overact. Definitely, we have to overact. And when I have very good press meetings, etc., I explained this thing, and the population, all the people understood that thing, and they said what ministry is saying is correct. We should have to restrict something. We should have to scientific propaganda, etc. People stand with us, and that way, each and every moment we are finding out the false propaganda and giving the answer to it. It is not an easy thing, but we are doing that. Anyway, we should have to do that.
Yes. Yeah. Is there, are you getting problems while the pandemic continues of, let us say, mental health in some ways? I mean, certainly during lockdown in Britain, there were some very bad family problems. And also, now that things have continued for a long time, not normal, there are also mental health problems arising. Is this true also in Kerala?
Yes, the mental health problem is the great threat for us. The people are frustrated actually. And when they caught this virus, they are acting, they are behaving in a peculiar manner, some people. And some suicides also happened here. When it started, we acted well. And we have a very good mental health wing here, and thousands of volunteers, counselors, and we are calling each and every people in each and every day and giving counseling to them. And through that counseling, we stopped the suicide activities or other behaviors due to the mental things. And I am dealing with the social justice department also, and women and children department, other than health department. And I have a very good team in social justice department, very good counselors, the school house counselors, and also the lower level counselors for social justice department. At once we called them together and give proper training, especially for these COVID cases. And we have very good these call centers in each and every districts, and especially trained people in that call centers, and people are calling to have their doubts and problems. They are addressing their problems. And when we quarantine the people in their home, our workers, grassroots level workers are calling them, our doctors are calling them. If there is another, if there is any frustrations or any excitements or like that, our psychosocial support, we are giving psychosocial support to that person especially. And I think we called more than 50 lakhs people for this psychosocial support, especially. And all the quarantine people, the more than 3 lakh 50,000 people, we called them, each of them, our workers called and inquired about their health status and mental problems, etc. That way we are addressing the mental health problem here. That's a severe thing. And after the past COVID, then also we should have to address this kind of problems. Not only mental health problem, but also some physical problems are also reporting after the past COVID scenario. And after the COVID, when they cured and went back to their homes, some are coming back. Now we are starting post-COVID clinics in each and every district to address that problem. Some problems in lungs and some heart problems also, and fatigue also, that kind of things are happening. And we are now starting the post-COVID clinics, not only in modern medicine sector, but also we are using the indigenous medicine for the post-COVID problem. We have a very good project called Punarjani in Ayurvedic sector. Kerala is famous for the Ayurvedic treatment, and they are for body pain and some breathing issue. We are giving some Ayurvedic medicines after the curing of the this COVID-19 from the hospitals. When they discharged and went back to their home, we are applying this Punarjani scheme also to address the post-COVID problems.
So I'm never sure whether Ayurvedic medicine has any pharmacological effect or not. I mean, it may have a psychological effect, but I do not know whether it has any pharmacological effect. There's another question, although we're getting to the time when I'm going to have to pass over to Toral Gathani to thank you for your collaboration and let you escape to other more important jobs. But when there is a vaccine that has been properly tested and approved, what sort of immunization program do you have in mind? I mean, the government of Kerala must have been giving some thought to what they will do when a vaccine becomes available. And I suppose it obviously depends on the cost. And suppose that an affordable vaccine becomes available. Could you describe roughly how you would envisage deploying it? How would you, I mean, Kerala has a very large population, larger than Britain. So how would, you know, it's going to take some time to get universal vaccination. How are you going to approach it if an affordable vaccine is shown to be effective, at least to have short-term efficacy? And that would be the last question before I hand over to Toral Gathani for the vote of thanks. How will you make vaccination happen?
Sir, we have to prioritize the things. If we get vaccine, I think your question is on that. What is the priority we are giving for vaccination? Am I right?
Yeah, your vaccination strategy when an affordable, effective vaccine becomes available.
Yes, sir, we have already prepared a vaccination strategy. Vaccination is not come, but we have already prepared a vaccination strategy for that. First of all, we will give, if vaccination, get the vaccine, we will give priority for the, first of all, the healthcare workers, because we have to protect them to save the people first. And next to the vulnerable people, definitely we have to reduce the mortality, and we have to give the vaccine to the old age people and other vulnerable people, comorbid people, etc. Because our first aim is to reduce the mortality rate. And then I think the other vulnerable part, any vulnerable part is there, we are giving priority to them and the volunteers and that kind of people. And that way we have to use most scientifically the vaccine, and we are trying to get the vaccine properly. And we are in hope that your Oxford vaccine will come soon. And if it comes,
I hope that a vaccine will come soon, or actually more than one vaccine. That's what the World Health Organization is calling for. They are calling for several vaccines to become available, which are all effective. But this is not yet true. Well, it's been a great pleasure to see you talking, to listen to you talking, and to hear from a place in the world where politics is rational. And I would like to finish by asking Toral Gathani, who is also an epidemiologist, as well as being a doctor, to propose the vote of thanks. And thank you very much indeed. Thank you very much indeed. It's been a pleasure speaking with you. And Toral Gathani, please, over to you.
Thank you, Richard. Honourable Minister, on behalf of the India Oxford Initiative, I would like to extend heartfelt thanks and appreciation for a really fascinating and illuminating presentation and discussion on so many different aspects of the challenges that are faced by the Kerala healthcare system, from both communicable and non-communicable disease. It's been interesting to listen to the similarities and differences of our collective experiences. We are so honoured that you were able to give us some of your valuable time, and we have all certainly benefited from hearing your perspective. Thank you. I'd also like to thank Richard for facilitating the discussion and for giving of his time today. Our thanks also go to the behind the scenes organisers, to Avni Gupta and the team at AFOX for technical support, and to the team at the Ministry of Health for facilitating the meeting. This has been the inaugural webinar for the India Oxford Initiative, and we're looking forward to many more events, and we will be circulating details about this in due course. I want to thank everyone for attending today, and I hope that you've all enjoyed the discussion as much as I have. Thank you.
Okay, thank you very much indeed.